You are listening to the Iser Health Podcast with your host, Dr. Josh Gilden.
Disclaimer. The information discussed in this podcast is for educational and informational purposes only. Always consult with a qualified healthcare provider regarding a medical condition or treatment. The views expressed by the guests and hosts are their own and do not necessarily reflect those of any affiliated institution.
Today we have Dr. Abraham Derman, who I've known for the past several years, who practices internal medicine, has a couple of piqued interests within the field of internal medicine that I hope we get to discuss at some point today. I like to start with a couple basic questions. First one is, what drew you to medicine?
What drew me to medicine? I wish I knew that exactly, but the one recollection that I guess one thing I should say is my father's a doctor. So he
Dr. Ben Doctor.
But I always
By the way, just so you know, we've had this before many times. We've spoken to Dr. Mand, who comes from a line of dentists, if I remember correctly. Dr. Seamus, also a line of dentists. But there's a theme of like the Dr. Ben Doctor, someone who's, which I find fascinating because I think it can go both ways. It's like right? So please get more into that for me.
Yeah, so as a child grew up, there was like no way I was going to be a doctor. I saw how hard my father worked as a physician. He was also an oncologist, so he dealt a lot with end of life and death, and it was just very, very stressful. So to me, becoming a physician was not going to be in my game. But then I guess my recollection is really mainly from when I was, I went to yeshiva, I learned in Kollel, and then at some point when I went to get a job, I started working as a special ed teacher for a period of time. And on one of my drives back, I remember clearly realizing that so many of these challenges that these children have are kind of autonomically driven. Like it was a behavioral challenged kids, and I really felt like if they could be in a way better helped if they had better medical treatment to help them manage their behaviors. And I was also inspired a lot, incidentally, by my wife works as a special ed therapist with autistic children, and she follows with a treatment modality called DIR floor time, which is pioneered by Dr. Stanley Greenspan, a psychiatrist physician. So this was like my more, I guess, inspirational as my long drives back from Brooklyn to Lakewood. I remember thinking like, that's what I would want to pursue. See, listen, like, I'm not yet 100 years old. I could try pursuing it, even though I started when I was 30 doing prerequisites. That was I guess at that point just let me try this, because I also had observed other physicians that were not as intense as my father, so I was like, maybe I could do this in a slightly different way than my father. That was, I guess, what started me off on the path.
So there are a couple of interesting things there, but the first thing I want to delve more into is, because obviously I'm a doctor, that's why I'm here. That's why you're here. But, I always think about how my kids perceive what I do professionally, because very little do they get to see me in a professional setting. They just get to see when I'm not home, the late hours, if I'm distracted at home dealing with something, which thank God is not too frequently, but it certainly happens. And I just wonder your memories as a child when your dad being an oncologist, which I imagine is busy, you're generally bringing work home, a tough field. I mean, when you're talking about bringing things home, so just a couple of memories or perspectives on just watching that as you grew up, how that perspective shifted over time.
Yeah, my dad was and is very, very dedicated, and when he would get on the phone, he used to speak to patients as part of, I think it was ECHO. These other referral organizations he would help patients going through the process of cancer treatments, and he wasn't necessarily the treating physician, but he would discuss with them options for treatment for various cancers. And I would hear him on the phone for hours going over and over, discussing with them, what the evidence was behind this, why it's not worth it to do this other thing. And it was in a way, I guess I'm sure there's some aspect of neglect, but it was also inspirational seeing how much dedication that he and how much he cared, I guess was showing care by just spending that time with them. So it definitely had a significant effect on me. it seemed out of reach as a child. Like I could never do that type of thing. But that was definitely a component of positivity there. Yeah.
Did you feel like over time your perspective shifted? Like, when you were younger, you didn't understand why he was on the phone for so many hours, and then as you got older, you had a newfound appreciation for it, and at some point you felt like, I kind of want to emulate this, because he obviously went back and did the medical route.
Right. It's tough to say. I mean, I guess I feel I'm still an evolving person. So, I guess I could say I'm starting to appreciate it. I've even had some people come to me from local community here that have told me how they remember my father spending hours with them on the phone. So, yeah, to some extent, I do emulate the meaning that this brought to him. That I think he had, like, his work was a physician in a state hospital during the day, where he would deal with the sick patients, but then he also had this extra time which he spent with patients, which was unreimbursed, and it was just, I guess, the goodness of his heart. And in many ways, I think, like, us seeing him retired, my father doesn't share his emotions very much, but I do feel like that had more meaning to his life than all the hours he spent in the hospital. So it definitely gave me a perspective of how sometimes the smaller part, like the extra things you do, can be more valuable, more important than your main job almost. Yeah.
I find that can be a theme in practicing medicine, where if you don't take time to smell the roses, right? The things that are, what's with that expression? The reason is because you're running by them and doing something else that you value or you think is more important. But the reality is the slowdown of, hey, this actually in the moment is the most important thing for me to do, and it'll make me appreciate everything else more significantly. For example, I had Dr. Mand over here, and I asked him something that he learned from his time, like stewarding in the hospital, just helping patients, without being compensated. That was the point, because he worked weekends, and this was when he was in high school. And something he brought up is, like, being a patient advocate he learned it by not being able to be a patient caregiver, provider, right? Like, he learned the essence of how do you take care of someone and advocate for them when you aren't caught up in the medicine and the science and the action of surgical intervention, which unfortunately sometimes when you are caught up in those things, which are noble and valuable and essential, it's very easy to forget the basic component of the job, which is the emotionally being present at the visit, considering people. And, I know we're both osteopathic physicians, right? And I know the word holistic can sometimes feels like it has a commercialized component to it, but the true nature of it, like to be there for the patient, which is what the patient values. Healthcare is a two-way street, right? So some days we're on one side of the road, and unfortunately there are days when we're on the other side of the road, and the only thing we want on the other side of that road is that the person taking care of us has that same intention. So when you kind of reframe it, refocus it, as that is the primary part of the job, even though we find it in the everyday life, oh, that's the accessory. He did that and it was unreimbursed time. Oh my gosh, we could have had more money, and then I could have had swimming lessons as a kid, whatever it is, right? But then you recognize that when you reflect, it's like, oh my gosh, that was the most value added to the day was based off of what he was doing. So that's something that I found to be a trend with people who are practicing medical care. Moving forward a little bit, you are not the traditional route of a pre-med, saying that you'd started your prerequisites a little bit later in life. That probably wasn't an easy decision, because I imagine there was some upheaval, right? Because the average traditional pathway, for those who are unaware, someone grinds through their high school education, their college education, all the prerequisites, 23, 24, 25, maybe 26, you hit that medical school door, and you grind for another 4 years, and you go out into residency, and you started the pathway later. So what was that journey like?
Yeah. So it was also an evolution. It started off ironically or interestingly, inspired by my neighbor, who was a sofer and also in Lakewood. And his wife was a physician assistant, and he at some point decided he was going to go to become a physician assistant. And at that point I was like, listen, he started at 39, we're buddies, we talk, like if he could do it, why can't I give a shot at it? And it was like during that period where I talked about that drive back, and it was just at the end of it was around June, it was around this time, and he was like, just sign up for some courses in RCC or OCC, Ocean Community College. And I was like, I've never been to college. I've been in yeshiva all my life, I don't think I'm so stupid, but I don't know what college is like, but it's not that much money for one, course. So I signed up for, I think it was Biology 1. And I really, I felt like I was enjoying the studying. So I said, let me go give a shot at this. See where it can go. As I'm taking the courses, I started realizing that if I'm enjoying the studying, and I do mental gymnastics of calculating life and time and value and things, and I calculated that I could spend 2-3 years and become a PA, or I could spend, the way I saw it was like more like 4 years in training, 4 or 5 years in training, but then become a resident, which isn't getting paid like a PA, but at least something, and then build up to something where I become a full physician. And the joke I always justify is my dad started residency, and most people start, or medical school, at a younger age, but life expectancy was at least 10 years shorter when he started. So we're starting at about the same time.
That's one way to put it.
Yeah.
But did you find that, I imagine at that point life had progressed for you a little bit more. Yeah. For me, when I started my journey, I was fresh out of college more or less, and newly married, and was able to move to Florida to start my schooling. What were the unanticipated hiccups of being firmly planted? It sounds like in Lakewood.
Yeah, so I mean, to be honest, we definitely, I went to Lakewood, went to yeshiva. We were at a point where we kind of wanted a little more of an open perspective, and we were thinking about also even just moving out of town communities. So we were looking for somewhat of a change in our life as a family, regardless. But it was a big challenge. When I applied to medical school, I applied everywhere. And in fact, I got accepted to Oklahoma, KCUMB. It's Kansas City University Medical, which is right on the border of Oklahoma and Kansas. So I was actually accepted and just about to go there before Turo called me and said, we have a spot for you here. And I was like, if I have a choice of going to Oklahoma or leaving my kids in like the Muncie type area, which would be easier for the family, I chose to go the local route. But it was always a discussion with our family, like, are we ready for it? It was a big decision. Yeah. And it's really, to my wife's credit, 100%. She supported me and agreed to go into the unknown. And it's been, she's super mom. She took care of all the kids, 5 kids during residency, medical school, and yep.
Yeah. Well, I mean, when I, once again, so I think I had my daughter in second year of medical school, and it was before I was studying for the step 1 for the first part of the board certification. And I just remember thinking like, oh my gosh, this is, and it definitely puts it into perspective when there are non-traditional pathways out there, and people have to deal with way more as they're trying to, climb the pathway of becoming a physician. And those stories are always inspiring, by the way, and then they make us want to work harder. Like, you had that kind of accessories with you through the process, and you still were able to get through the other side and become a successful physician, and more than a successful physician. It also highlights that I don't think everyone's acutely aware. Maybe some people listen, but there are so many branch points in this process, right? My wife and I always refer to it as a dark abyss, where you really have no idea what that future looks like for a period of time, because there's a lot of uncertainty, right? When you talk about getting into med school, well, geographically, where are you going to live, right? When you talk about board scores, well, I know the process is slightly different now, but those have a significant impact in the type of medicine that you're ultimately going to practice. And then you have to do residency interviews, and you have to get into the specific residency. Once again, another geographical location change, perhaps. maybe or maybe not in the field that you had anticipated working in initially. And that's why we call it the black abyss, because the world in front of you is constantly shifting. But think, it's one of those Yad things. It all tends to work out in the way that it's supposed to. You just have to have faith in the journey, and also, the Hishtadlus Emunah component, like do the best you can, but the end product is not necessarily going to look like the product you expected. I can't remember whose quote this is, so I feel bad not quoting it. I'm not quoting the person. I'm also not quoting it correctly, but life is what happens while you're making other plans, right? So it's just like your plan was for A, and then all of a sudden B happens, and you have to adjust. Speaking of, so was your plan always to go into internal medicine, or?
No, it was definitely evolution. I still don't know if it's over. I enjoy so many aspects of internal medicine. When I started at med school, I was more leaning definitely towards the mid-med school. I was thinking more towards surgery, because I do like doing a lot of handiwork myself. So I was thinking orthopedics, fix bones, put in knee replacements like that. There's a lot of my handy side that can get to that. But I was also very much driven to the brainiac part, the thinking part of internal medicine. And after doing a number of rotations, there was Dr. Albu, a physician, an endocrinologist at Mount Sinai that I rotated with, and she's an endocrinologist with the obesity department there. And it was very inspirational seeing her, working with her and just seeing the effect she was making on people's lives. And seeing various, role models, it really, I got drawn much more to orthopedics. To internal medicine from orthopedics. And then, to be 100% honest, it's also the competitiveness, the nature of medicine the way it is now is to get into something like orthopedics, you have to kind of give your whole life over to them. And I saw the internal medicine route being more compatible with family life, family values. So I once I was seeing satisfaction working in this type of realm, that was a big part of what I did. What helped me decide to go to internal medicine. I still do always wonder if I should go back to do endocrinology, because I love so much of the endocrine system, and a lot of my practice is involved in diabetes and endocrine problems. So, yeah.
Well, you've proven that you've done it once, so you can certainly do it twice.
Yeah, exactly. That's what I feel about it. Is as much as you say how it's so much credit for me doing it later with so many kids and it being hard, I actually think in a way it's harder when you do it when you're younger, because your first child, your second child, that's a big change. I only started med school after I learned how to be a father. Not that I ever know how to be a father, but it's I only started after we were a little more established. There's a lot of challenges, but it wasn't in the founding of our family that I started it. So in that side, I actually think it's even harder when you start younger. But yeah, there's no reason why I can't go back to fellowship and do some other training. And even not going back to fellowship, once you have your medical license, you can technically practice any part of medicine. So you can specialize. You may not have the board certification, but you can focus on an area and become really good at that. So that's, yeah.
You won't see me taking out appendixes, I promise you that. But, no, but I think what I take away is that there are, certainly in medicine, there is a desire to practice a specific form or way of medicine, but the reality is medicine is also a lifestyle, whether we like it or not. So if you're going to adopt practicing a particular specialty, you have to be ready to take on board everything that practicing that specialty entails. Now, you could find a niche where you get to practice in a way that maybe doesn't have all of the downstream consequences, but the reality is if you're going to be a specific form of a surgeon and be on call with a specific amount of frequency, that's going to affect your home life. And if that's the trade-off that someone wants, and the Gesundheit, that is the trade-off that they should go for, but it would be naive for someone to assume that they can have the best portions of a specific medicine field and without any of the trade-offs, right? There's always a trade-off system that exists. And the other thing, and this happened to me in my process, I was an EMT before medical school, so I had a sense that was what I wanted to do. There was a sense of finding your collective people in medicine, the people that you bonded closely with, that you were around them and the humor seemed to resonate with you and the personalities also resonated with you. Obviously the practice and the field itself, But it was almost like finding a tribe, so to speak. And that was a big deal for me. So I imagine that was something that you noticed as you were going through your training.
Yeah, that's exactly it. I think that is very, very real. Like, I felt like my skills, I think I would be good at fixing bones. I think I do love the idea of being able to, cut somebody open and fix them, even general surgery, taking somebody who has, an appendix that's, about to blow up, and you put them in an hour or two surgery, you cut them out, and the guy wakes up and he's, in good cases feeling totally fine. There's something so satisfactory just being able to fix something with your hand right away like that. But I didn't feel a connection, for sure not with the orthopedic friends. So that was definitely an aspect that I was my tribe definitely was much more towards the internal medicine, the endocrine, and the people, connecting. And there was one of these Facebook reel things that was asking, I think it was a neurosurgeon, asking what each specialty of medicine, what their trait is, and it did. One of the, I forgot exactly what each one was, but they said that the internal medicines tend to be the better teachers. And to me, that's something I really always felt with me, is like I enjoy being able to give over things to people and explain and give you something to take with you. So like surgery is cool because you fix it, but there's not really much of a teaching component. I mean, some areas of like surgery, there is a big difference what you do afterwards. But internal medicine is so much being able to, like, in an ideal world, empowering the patient to take care of themselves. And I really like that aspect of being able to, like I think it's the Rambam says it's better to lend somebody money so that they can learn, they can borrow the money and build their own business rather than give straight out charity to them. And I feel it's a similar concept in medicine. If I can teach somebody how to manage their health better, that's the best, favor I could, generosity I could do for them. Yeah.
I hope we didn't lose any of the orthopedic surgery followers of the show, but yes. No, I understand what you're saying. Yeah. I think what's funny for me, and I wonder how you're going to take this based off of your perspective, is that when I went into emergency medicine, one of the biggest draws for emergency medicine is the procedure component to the field. It's procedure heavy, obviously, while you're taking care of patients in an acute setting and high acuity. So people go into it because of the intubations and the central lines, which are big IVs that we have to put in for critical patients, and arterial lines, special catheter that goes into an artery, laceration repairs, et cetera, et cetera. And the more I practice, the less excited I am by doing these procedures. Not that I'm not proficient and make sure that I'm good at them, but the more time I spend recognizing that every procedure I do is on a human being and affects a human being, and the quality of my work can have a lasting effect on them. Obviously, if you're talking about a laceration repair on the face, how well you do it is going to have a lasting effect. And on the other end of the spectrum, if someone's critically ill, you have to put a tube in or to take their airway or put them asleep. But obviously, a critical impact, and you have to do it with nuance. And you have to make sure that you're doing it with the best, latest evidence and the research available. But I get less excited about it, and not necessarily more nervous, but I guess the magnitude of just taking care of people. So I actually like talking more at this point, because I enjoy that the education and conversation of talking with someone. You can theoretically have such a large impact, but it's the cut to cure mentality. In order to make something better in surgery, you kind of have to do something that unfortunately looks terrible, right? I always say the irony, if a kid, God forbid, gets a little cut in his head near the eyebrow, what do? Okay, fine, I'm going to do a beautiful job. I'll numb it up. I'll make sure that take him out as much pain and anxiety as possible. Give him a lollipop. But I have to take a small needle, the smallest needle I can find that will get the job done. And I have to go through perfectly okay skin on the side. And this, I think the time for that eventually will change. I think that there's enough devices, and the evolution of equipment's going to get past the point where we have to do it like this. But I always thought it's ironic that it's like adding insult to injury. The person has a laceration, and now here I am with a needle just going in and out. Now, once again, it's for cut to cure, for a good outcome, but just as time goes on, I appreciate not having to physically perform medicine, and I enjoy the conversation of medicine. So, I think we're, you want the thing that maybe you didn't have, but it definitely, there's a strong value to the communication of medicine. There's a bunch of, things that are changing the medical landscape currently. I think the biggest one is probably technology in healthcare. I know in the community that we service, technology can be a tough subject, right? And the level of integration, interaction is certainly a nuanced question. And I'm just curious, in your day-to-day practice, what has been the biggest difference from day zero to now that you've noticed?
So I guess it's just been a culmination of mind-boggling changes. I guess one thing is, I always like to preface it because from the one side, the promise that there is in medicine is mind-boggling. The amount of advances that we have are phenomenal. Now I'm going to go into like the practicality of that, but at the same time, the challenges that people face on being able to get these things is also huge. I have so many patients that are not able to get the treatments that they need because of money. It's like supply and demand. 100 years ago, if you were sick, you went to the doctor. You're lucky if you got antibiotics. Now, if you're not sick, you go to the doctor, and we have 10 medicines we can give you to make you live longer. So I almost like people come to me sometimes for like vitamins, and they ask me, and I try to tell them that I think my medicines are vitamins. I tell them my cholesterol medicine, it's a vitamin for your heart. My blood pressure medicine, that's a vitamin for your kidneys and your heart and your brain. So, I like to think of it that way. But the biggest changes, I would say, honestly, it's all the rage in the world nowadays is the talk about the GLP-1 medications, the Ozempic, and this Dr. Albu that I referred to I was in fourth year medical school, and I went to, it was an endocrine fellow presenting the early research at that point showing that how GLP-1s can be used for weight loss, and to how we need to view, obesity as a disease state, and it's something that we can treat. This went from I think less of a mainstream thing to the point now that I think most doctors do agree that it's something that we can really, really treat. And we did have surgeries for weight loss for a long time, but surgery is a big deal, like you're talking about, cutting up your body and having to change it. It's the right thing for many patients, but it's a big deal. Having now a tool of at least 2, 3, 4 medicines that we can try on a patient to help them, lose weight. And these medicines are used for diabetes as well, primarily for diabetes, and see patients that were on 3 times a day insulin and having low sugars and high sugars to being able to be on 0 insulin. The medication advancement has gone significantly better since just even from starting med school. The improvements and changes have been drastic. From the technology perspective, it's really, really up and coming now. There's a concept called a constant glucose monitor, which is changing the way I'm able to treat diabetes. It used to be like some physicians are worried about using insulin. You need to be comfortable knowing how strong your insulin is going to be, because insulin is a strong medicine. It can lower the sugar to a dangerous level. But having a tool as a constant glucose monitor that with the right connection can even allow me to download onto my computer all the information for 2 weeks, it can give me a confidence to say, come this week, I'll start this dose and I'll tell exactly what it did to you while you were sleeping. I don't have to worry about maybe that time you weren't feeling well, maybe it was your low sugar. I can see that on the chart. I can see what it is. It's empowered me to really be able to control somebody's diabetes. As long as you come to me and you show up, I can track it, see it, show it to you. If you had symptoms, we can say, that time that you didn't feel well, let's see what the sugar looked like during that time. So that advancement, and now on top of that, there's combined with that constant glucose monitor, there's a concept called a automated insulin pump Omnipod is one of the common ones, the one that I use. It's basically,
not that we support any specific brand.
yes, but it's used when I give insulin, traditionally you give insulin, long-acting insulin at night. Sometimes you give pre-meal insulin. You give a high dose to the patient. It's a relatively high dose, and you hope, you use your logic, you use your measures, you do safety things, and you give the amount, and you hope that it's a safe amount. And our training teaches us how to do it in safe manners. But you're ultimately putting something in the patient, and as an emergency physician, I'm sure you've experienced patients that have come in with persistent low sugars because they ended up with too much insulin in their body. The constant glucose monitor with the Omnipod pump is giving only short-acting insulin in very small amounts every 5 minutes. So it's making it a much safer way of giving medicine. It's like having a nurse stand by you every 5 minutes. Oh, let me see your sugar. Okay, I'll give you a little bit more insulin. Oh, let me see it now. It's going up. I'll give you a little bit more. It's not something that's feasibly possible without this technology. And so this technology of being able to get, I have one patient that was using over 150 units of insulin every day. And that's a lot of insulin. And I was like, she has a very difficult time getting to an endocrinologist, and like, I'm having to refill this, and this is like an older patient, and it's well known that older patients, you run the risk of their sugars dropping low. But her sugar levels were elevated. Her A1C was over 11, 12, and we kept on giving more insulin. When I got the insulin pump on her, it was giving her over 200 units a day on certain days without dropping it low once. So it allowed me to be able to do something that I would not be comfortable doing if I wasn't an endocrinologist. Having that machine saying, okay, we're giving it now for 5 minutes, a dose, and I'm going to check what the sugar is and see a response. It's just enabling much, much better control and treatments that would not have been feasible before. Yeah.
The two things I take from that is that we live in a world of data, and we live in a world of monitoring that there's never been before, right? Yeah. So, for example, the data out there is astronomical. Mm-hmm. There's so much information out there, and the ability to monitor it, Apple Watches, for example, with the ability to detect atrial fibrillation and, this glucose monitoring system, and it, with that level of data and monitoring, it's amazing, right? Mm-hmm. And I always hear the voice of what's the evidence at the same time, right? Mm-hmm. Like you have to practice, everyone's monitoring their sleep, right? Like, oh, I got this many hours of this level of quality of sleep. Mm-hmm. And it's kind of like, and then if they get a bad reading, they have a bad day because, almost there's a psychological yes. component that probably exists. Yeah. And, it's kind of the interplay between the benefit we get from this, the unknown benefit and mm-hmm. the known benefit. Also, probably the unintentional consequences or harm, especially when you're talking about the evidence-based world. Because, I guess the question I have for you is, even though this is something that you've implemented, what is the evidence on this kind of system, and how do people use it, and what's the future of it? Because it sounds pretty new, and it's not something I'm intimately familiar with.
Yeah. So they are studying it. The evidence is they've shown at least 2 or 3 points of drop of A1Cs in patients that use this. But the most important factor of it, more than the drop in the A1C, is the lack of low sugars. I can't tell you how many patients of mine are always worried about that low sugar, and they're rightfully so. People can even die from these low sugars. And having a machine that is giving you a small amount of insulin and it's programmed to avoid low sugar. So it may not get the sugar all the way down to 90, which you don't necessarily really want it at. It's going to stop. I feel like I'm selling the product here, but it has its algorithm built in that it's actually watching the trajectory of the sugar. So if the sugar now is at 200, which is high, right? But it was just an hour ago 100, it'll stop giving insulin at 200 already, because it sees the change between before and now. It's going to say, whoa, this person's sugar is really dropping. They're getting sensitive to this insulin. I'm not going to give any more insulin now, so that we don't end up at a 50 in 2 hours from now. So they're constantly studying it. But to me, this is just the opening of the Pandora's box, because once we've got this system in place of, like we talked about, monitoring and be able to review, it's only the next step when we can actually start actively making changes. Like, I could technically, theoretically, there isn't a reason from a purely technical perspective. If I'm able to read everything, there's no reason why I can't actually talk to that patient over the phone and change what their pump is doing and say, oh, you need more insulin today. Okay, I'll just adjust the pump. And then if we start expanding this to antihypertensives, you can actually, there's a concept called a 24-hour blood pressure monitoring cuff. There isn't a reason why we can't have the same type of pump injecting a very small amount of antihypertensive and connected with your constant, monitoring your blood pressure. And we don't have to give you a blood pressure medicine and say, come back in 2 weeks and we'll see if it is. It'll give you a week of this. Machine will figure out exactly what dose of medicine you need. And instead of having to have a pile of 5 or 10 different medicines that you're taking out here, organizing from this bottle to the next, just have one little thing you plop on your skin, and we go over what this machine gives you. There's no technology out there for it right now, but the foundations for it are there, and it's just a matter of time till this all goes into effect. And it's exciting seeing these things happen, because there's so many things about medicine that are so dependent on practicality. There's medicines we could do to treat everything, but one of the biggest challenges in older patients is polypharmacy, is that so many medicines they're on. And as an emergency physician, I'm sure you've had patients come in totally confused because they took 10 of the wrong medicine instead of their 10 different medicines. So it's there's just the advancement of the technology and how it's becoming automated and simpler for the user to use is, to me, one of the most, even though it's not rocket science, it's not none of this is like some kind of complicated thing. It's really just putting technologies that all exist and bringing them into practicality in a way that is making life easier for people.
Yeah, I'm all for the convenience of medicine and the technological implementation. I think there are so many advances, obviously the weight loss drugs that are currently in vogue, let's say, and the benefits that seem to come out of that. But and what you're postulating where the future could be as far as getting a more steady state improvement with a lot of the medications, that unfortunately we can't do that right now from a practical or technological standpoint. I also get nervous because I know as a physician that the primacy of healthcare is so much more holistic than the implementation of the treatments that we have. And what I mean by that is that the value added of someone leading a healthy lifestyle and what happens when you can almost automate all these interventions that, I don't want to say negate the necessity for a healthy lifestyle, but almost make it seem more trivial. I think right now the advantages of someone leading a healthy lifestyle in a very holistic sense, what they eat, their lifestyle, their Seder Yom, there's a value in doing all that the right way. And certainly medication's not crutches, but if we can automate a basal antihypertensive, anti-obesity, Lipum Sara Agra, right? Like the concept of you put in the effort, you get the reward. I think that there's either a limit to the other way of doing things where we can only facilitate so much in a convenient fashion, or if there is no limit and you can facilitate someone to be in perfect health at all time without trying. What are the ramifications of doing that?
Yeah. So, I mean, this is definitely a real thing. And I mean, there's a pharmacist was coming to me or was talking to me about this the other day, that the death rate, the chief cause of death in people in the world has been heart attacks, basically, cardiovascular disease. But this has actually predated the obesity pandemic. It's been since the early 1900s that cardiovascular diseases kind of hit. And he was asking, why is that? If we're so able to, if obesity is the main thing, why didn't it go up with obesity? And it's not clear how much it's dropping. It is getting better with these GLP-1s and the improvement of the obesity with the drugs. But there's multiple. There's a book by Peter Attia. He's a physician that started as a surgeon, a cancer surgeon, and turned around and saw the light to become an internal medicine longevity physician. And he focuses on all these, how there's so much that he has a book called Outlive, where he talks about so many things that you can do to improve not just your life, but your quality of life. And the thing he talks about over there, and there's multiple studies showing that physical activity and exercise is more important for longevity than anything else. So my hypothesis is that that's the reason why cardiovascular disease went up before obesity. It's because of the automobile, actually. The cars is really what killed us. The fact that we no longer have to work hard getting in and out, walking to the store, and we see this a lot also just there's worse obesity in rural places where everyone has to drive to get anywhere. You would think you live in the country that you're going to be more active, but it's actually often the opposite. When you're in the city, you walk to a local store. So physical activity, lifestyle is actually more important than anything else. The way I see this is if we can simplify the treatment of medicine, it can make it that I could spend more time fussing with you about exercising. You come to me, I'll fix all your numbers. But if you really want to live long, I'll give you the thing to fix the numbers, but you got to get on the gym. You got to exercise. You got to, really be active in life. And that's 100% true. That I don't foresee it in the near future that medicine's fixing a lot of the lifestyle changes that we need to make just to enjoy not just length of life, but quality of life. The idea of the big thing about what Dr. Peter Attia talks about over there is that you don't want to be living in your 80s and barely being able to move. You want to be in your 80s being able to walk and do whatever hobbies you enjoyed. So it's about keeping your body in good shape, and doing that is a lot up to what we physically do.
I always think about aging gracefully and not reverse aging. I know that reverse aging is all the rage. People are looking for the thing that is going to prevent them from getting older, the gray hairs, and it does. This is the chalice, or you're looking for what's the term that everyone uses, the magical river that reverses aging. I can't remember the phrase off the top of my head. Yeah. It'll come to me in about an hour from now when we're done with the podcast. But
Fountain of Youth.
Fountain of Youth. Thank you.
Yeah.
You saved me a lot of anguish over the next hour, so I appreciate that. But everyone's looking for the Fountain of Youth serum, which we know doesn't exist. So it's about aging gracefully and not reverse aging. Yeah. And I think that's what a lot of grifting, a lot of snake oil salesmen is, specifically in the industry where people are looking for that kind of reward. And the reality is I view medicine as an adjunct to lifestyle. And what you're saying is that we need to help them out, right? Like if someone is 100 pounds overweight, exactly, you can't necessarily expect it to be easy for them to get into a fitness routine without just taking off some of the excess that will make it easier for them to do it. So it's about facilitating them. And also there are people that optimize, let's say, the blood pressure to the best of their ability, but there's a genetic predisposition. Yeah. Well, then they need this medication, and it's about identifying that point where you've optimized the things that you can do, and this is supplementing your lifestyle care. Yeah. And I think the problem in American healthcare occasionally or frequently is that because there's not a full understanding of science and medicine, there is maybe a fundamentally flawed belief that if someone gets themselves into a problem, medicine can be a solution to it. And unfortunately, more often than not, medicine is not the solution. Or even if it does solve that problem, there's generally a trade-off, and it creates a new slew of problems that sometimes are anticipated and sometimes are unanticipated. And I don't want to say the most foolproof method, but certainly the most tried and true approach is just by doing the things that everyone kind of knows inherently, which is the diet and the exercise and working on the lifestyle, and making sure that you're supplementing with medication as is essential. The role of the medicine physician, which I don't know that we've fully explained, so I guess I should ask you for your explanation of what it means to be an internal medicine doctor. Yeah. So I'll ask you that question, but I'm going to ask a part one and a part part A, part B. Part 1, part B doesn't make any sense. But I'm going to ask a part A and a part B. So, what is a medicine doctor? And the role of a medicine doctor, historically speaking, has changed significantly. And I think a lot of the shifting has to do with how healthcare reimburses in general, and also how society views a physician, specifically a primary physician. So if you can just enlighten us on what a medicine doctor is and what that job entails, and also how you see the field shifted up until now and kind of where you see the field going.
Yeah, so a medicine doctor could be called a primary care doctor, can be called a urgent care doctor, can be called so many different flavors of an internal medicine physician. It means we're primarily trained in dealing with chronic medical problems, but also acute medical problems. It's kind of a little bit difficult to pinpoint it exactly. That's why some people don't like it. And the interesting thing about it is it's still so variable. There are many internal medicine physicians that will practice very differently in the exact same, health center, exact same place, and it's so how you mix your pot. So for me, this Peter Attia is actually quite an inspirational book that I read, and I felt that he really resonated with me. He makes this whole distinction between medicine 2.0, where he focuses that medicine shouldn't be reactionary, like coming to me for a problem and fixing it. Really should be going out to fix things before they become problems. And for my practice of medicine, that's really how I view it. When I see a patient, I'm looking at them to see what problems we can prevent in the future, how we can improve their quality of life and their quantity of life. So when you're seeing me, I'm looking at the blood pressure. Blood pressure of 140, you're very unlikely to get any serious problems of that now. But is it going to be overall stressing your system that by the time you're 70, your blood vessels are stressed? Very possible. So I would want to discuss lowering a 140, not because it's going to do anything today, but it's to keep your engine running smoothly for the next 50 years. Same things with cholesterol. So many of us have high cholesterols, and do we treat everyone with high cholesterol medicine? Not necessarily. So there's a lot of patients I send for a calcium score where we scan the heart to look for signs of small blockages that are early warning signs for trouble that can happen in 20 years from now. So I really do view myself as like trying to catch things well before they happen, before they become an issue. I ideally, like in my ideal world, I'd like to see a patient and prevent him from ever needing a stent in his life. Like if I did my job good, I should be able to make sure that I pick the right patients that need to be on medicine or on exercise. But if I'm monitoring them correctly, ideally avoid many of the treatments that are needed to save people. My goal is to keep them away from from the emergency room,
That's
from the that kind of thing.
That resonates with me because once again, just from a practice pattern, the more I practice, there's a certain monotony, and every patient is individual, and I really walk into every room just trying to treat the person in front of me. But there are running themes, specifically in an urgent care, acute care setting, or an emergency room setting where they're called risk factors for a reason, right? These are your risk factors for a bad outcome. And when I see people coming in with 40-something with a bad family history and high cholesterol and hypertension, diabetes, and they're overweight and they have chest pain, I am very, very concerned because they have hit a lot of the risk factors that predispose them for having acute coronary syndrome, for a bad heart disease and a significant heart event. And I think in the acute setting, well, what can I do now? And I think about the treatment modalities that we have, and some have good evidence and some don't have great evidence. I always think about, there's a website called The Number Needed to Treat, which once again, I'm not an expert in everything science and medicine, but, and if I'm quoting this wrong, someone please correct me. It's what I recall from my memory, but, I believe aspirin, which we give to people in acute coronary syndrome having ACS and in a coronary event, right? 324, 325, right? The number needed to treat, if you treat 42, then you've improved morbidity in 1 out of 42. And that, from a number needed to treat perspective, I know that doesn't seem like a lot, that's like some of the best numbers we have in medicine, right? That means if you do that on a population level with hundreds of thousands, millions of people, you're saving a lot of lives by giving aspirin. And there's a lot of evidence and a lot of things that we do that don't have such a good number. But this is something that I know as a practitioner. And it makes me, obviously it makes me want to do the best for the patient in front of me, but it also makes me think like, it's not a number needed to treat of 2. It doesn't mean if I see 2 people, one of them gets the benefit. It means I have to see 42 patients to perhaps get one who benefits from the treatment modality. And that's a scary thing for me to know. And it almost like scares me into trying to be healthier, because I recognize that it's probably the same thing for anti-hypertension. I think I've heard people talk about this, where it's like you control a lot of people's blood pressure. It doesn't necessarily have the same effect on all of them. And it doesn't necessarily save all of them from a downstream sequela of having, that you'd assume it would by giving them an antihypertensive medication, a blood pressure lowering agent. So it's the scary part of medicine where you're being proactive, I'm being reactive, right? It seems like, oh, this is the doctor who's going to take care of the problems. But the reality is that sometimes the treatment modalities are not where they need to be at to really take care of a patient in a way that if we had done prophylactic preventative medicine, like what a spoonful of preventative medicine is better than a lake full of reactive medicine, right? Like the amount of catch up you have to play when a bad event has occurred is so significant and sometimes insurmountable that the problem is that's when the emphasis is there. That's when the emotions are there. That's when someone feels the ramifications of healthcare. And that's when someone's inclined to make a change versus, I've already said it multiple times on this podcast, I'm the worst patient. I can't tell you the last time I've seen a primary, but I try and work out and do all the right things for my health. But, it's time for me to book an appointment with you probably, but,
The best medicine is exercise. There really isn't a better medicine than exercise. But to what you're saying about the blood pressure, and one of the things that is so encouraging in the field of medicine now is that our glasses are getting better, our binoculars are getting better. When I measure cholesterol, there isn't just an LDL and HDL now. There's an apolipoprotein B, which is another form of high-risk cholesterol. There's a lipoprotein(a), which is a genetic form of high cholesterol. There's high-sensitivity CRP, which looks for the amount of inflammation. There's a lot more measuring points that we can look at, and it's able to. I do feel promise in being able to catch some of these patients that in the past were told they were fine. And with coronary calcium scores, I have a lady who was in her young, mid 40s, but her brother had a heart attack at a really young age. So she went, I told her to go for the scan, and it showed early signs of blockages. This is somebody who runs on a regular basis. So this was somebody that would have, hopefully now she's starting on a cholesterol medication. Hopefully she'll never get a heart attack. Hopefully we're treating it, when it's very small. But these type of people are people that in the past we would have totally missed. And it's kind of scary, but kind of enlightening, getting more and more tools. Every year there's a new thing that comes out. With kidneys, we're monitoring with better blood work than there was in the past. There's a test called cystatin C that I'm able to see early signs of kidney dysfunction much more accurately than the traditional creatinine test that has been sent. So it's my toolbox. I feel like like I'm in Home Depot with a bunch of new tools.
So on that, it always reminds me of the discussion we had, a few minutes ago about signal and noise. Where it's with all the increasing binocular capabilities that we have, it's trying to identify the signal versus the noise. In my field, a classic one is if someone orders tests indiscriminately, especially in the emergency department, one test being a D-dimer, which is, inflammatory and coagulopathy kind of marker. Right. We use it to identify if someone's likely to have a blood clot of some sort. Right. If that test is ordered indiscriminately, it's noise. When it comes back high in a patient that wasn't really the correct patient population to do it, and what do you do with that information? Because there's detriments to doing downstream testing when it's unnecessary. Everyone, I hope that's clear. People certainly should know that when it's necessary, it's absolutely necessary. But if it's unnecessary, there could be certainly negative sequelae, negative downstream events. Versus when it's signal, when it's like you pick the right patient, it was elevated, and it guides you in the correct therapy. And, and obviously in your domain with all these new markers coming out, trying to identify the signal versus the noise. And the other thing is, like you said, the prophylactic therapy that you're trying to provide and that particular patient that you were just speaking of and trying to prevent her from having a heart attack. The unfortunate reality about the healthcare system as it stands is it compensates better for someone having a heart attack and getting treated for a heart attack than for the effort to prevent that from happening. Now, I know there are changes, and the healthcare it's a very large machine, right? And part of what this podcast is doing is just trying to be another, hopefully, voice for good that kind of is a game changer and promotes the machine going in one direction. But it's tough, right? If you show me the incentive, I will show you the results, right? A lot of the incentives are not necessarily aligned with giving people the best care, and that comes into play when people need to find their healthcare provider and make those decisions, right? You have to make sure that you're with the right provider and they're influenced in the correct way. And it's easier said than done, which is, I think, what, a lot of the fear and paralysis in medicine is maybe simply just choosing, like I haven't chosen an internal medicine doctor yet. You're a great guy. I'd obviously choose you. I should go to you. But, it's a fear of, well, what if it's not the right person and they don't optimize in the right way and they take me in a specific direction? And it's a lot of fear for just the possibilities of not getting the right healthcare attention, which is, there are a lot of great actors, but there's the reality that, the system is not perfect and not everyone's going to be perfect. And another reason why we're doing this is because I believe that we've cycled back, how you were talking about being a primary care doctor, used to be going to your house, right? Like there was the doctor that showed up at the house when the child was sick, and there's like that classic photo of a physician sitting at bedside of a sick individual and like contemplating and being pensive over what's going on with this patient in their home. And medicine's been reversed. It's been taken out of the home and institutionalized and brought into the hospitals. For better or for worse, obviously there are things where it's necessary, but I think that there is a trend towards people wanting that healthcare at home. We were trying to figure out a slogan for what we're doing here. And I said, the Eyes Are Health podcast, bringing healthcare home, right? Like you will trust a physician if you connect with the physician, because I believe we're past the age of information. There's so much information out there. You can find anything to support what you currently believe. And in order for people to follow my treatment regimen, I need them to just connect with me and feel like, you know what? Dr. Gilden has my best interest at heart. I'm going to follow what he says, because you can find 1,000 people who disagree with me on any particular treatment decision or modality. But in order to get someone to follow your pathway of care, which once again, hopefully you're doing it authentically, right? They need to connect with you. Otherwise, they're going to figure out something else that benefits them more.
Right. Yeah. The connection is absolutely there was a famous saying, I think it once says that nobody cares how much you know till they know how much you care.
I've quoted that like 4 times on this podcast so far in every episode. It's been brought up, this time by you. Yeah. And that wasn't a plant. I didn't put that there. So that was you authentically. And I think it's attributed to Teddy Roosevelt.
The challenging thing is sometimes people don't necessarily see when you care. When they see you focusing on your numbers, they don't necessarily feel it. So it's important to actually bring that feeling across. But yeah, connection is the last human thing we have left.
Right. Well, it's funny. I've kind of postulated that the way healthcare is going is, I could foresee a future in 10, 15 years where a patient goes into a room, a sterile, beautiful, clean looking room, and there's essentially a seat there. There are some devices that are not recognizable to us right now because we can't really predict what they're going to look like. I wonder how this is going to age, by the way. But you put on, for example, a watch, and it's going to get your pulse ox, and it's going to get your heart rate, and it's going to be capable of getting your blood pressure as well. It's going to feel your skin. It's going to know your temperature. So you kind of put that on. You're sitting in front of some form of a screen. You don't need to type anymore because it's going to be able to identify what you're saying. And, you say, hey, my foot hurts. And the machine can spit back and be like, I'm sorry to hear that. Is it your left foot or your right foot? And it sounds sympathetic, but it's just garnering the next piece of information. There's no humanistic element to that. And then you say your left foot and you're like, oh, once again, I'm sorry to hear. Is it in the back? Is it in the front, the top? And maybe even shows you a picture of your foot and you tap where it is. And what I'm getting at is in the most organized, educated, intelligent fashion, it might be able to identify the exact source of your pain. It might be able to list a differential of 3, 4, 5 potential causes. It might even be able to prescribe you that next study that you likely need, and maybe even the follow-up study, and even give you the referral to the specialist. And it might be way more effective than our current healthcare system. But the one thing it will absolutely lack is humanism, which is what I kind of tell my team on a daily basis. The thing we have to dive into is our humanistic element, right? Because that is the one thing that really is not replaceable. And I want patients to get the best possible care. And if that's how the best possible care is conducted, okay, great. But I do believe that there is, I remember I went to a doctor once, only one time. That was the only time I ever went to a doctor. No, I went to a doctor once and they put a stethoscope on me. And I know what they're listening for, and I knew I wasn't wheezing, and I wasn't concerned about other things that they felt like there was a healing property there. I felt good because their hand was on my shoulder and the stethoscope was on my back, and they said, take a deep breath in. And I took a deep breath in, and I was like, okay, I feel like I'm being cared for. And I don't know how to express that because I'm very educated, and I kind of knew that it wasn't going to yield any results, but it also mattered at the same time.
I wish I could fully agree, but I think actually they did some studies on many of these AIs, and their emotional quotients are better than humans. So I hope that the humans, that part's still the things, but I wouldn't be surprised if this type of system actually even grows to a point where you go to a doctor and you'll feel reassured by the emotional interaction with the computer, which I could imagine it, but I still think there is going to be a very important role for humans in for a long time coming. But it's I don't know if it's as black and white to say that emotional support does not come from a well trained and calibrated AI, but that's kind of a separate discussion.
I think that the crunch of medicine tends to be the part that drowns out the humanistic element, meaning that, from an ER perspective, right, the multitude of patients that need to be seen and sometimes how they can accrue on the waiting list in the waiting room, getting roomed, that burden makes it harder to spend extra time with the patients and to really sit there at bedside and be there for them and empathize and sympathize and give the reassurance that's required. So I'm hopeful that as healthcare changes, the thing that gets augmented is we identify how we can offload some of the clinical stress. Because, I think if physicians had to name their top burnout components, the charting would be a massive component. It is a massive component on most studies, as far as I know, right? And there are multiple different industries working on chipping away at that. Now, I don't know how successful they're going to be, but I know they're working on it, and I'm trying to integrate it. There's also the idea of offloading, urgent care is kind of sprouted out with, offload some of the lower acuity complaints, right? Yes. So if we can optimize healthcare to really have the doctor functionally doing the doctor role, I think that will go a long way in kind of providing a better ear, a better humanistic aspect than maybe we currently provide.
Definitely. I definitely think that is a component that there will be a big benefit to patients, is allowing the doctor to be present and like you said, taking off so much of the stress from unnecessary things, from documenting and maybe dealing with simpler things to maybe even just giving a pre-rundown, like in the early stages of it. You'll come in maybe the AI will be able to tell you the basics of your condition, and now you come and you talk with the doctor, and you've already had a basic discussion, and it's more of a nuanced discussion now, exactly how you want to go ahead with it. But yeah, I do think I definitely see it being a complementary role for quite a while. Yeah.
For people who maybe haven't had a checkup in a while and are a little resistant to go to a doctor, can you explain, especially, I imagine younger people, right, who overall feel pretty good and healthy. Can you explain the value of establishing a primary care provider? And can you also almost give us a synopsis of what people can expect and maybe take the anxiety out of me making an appointment? But the average person making an appointment because they know what to expect.
Right. So to me, it's so again, each physician does their practice differently. The way I usually do it is for younger, very young people that do not have a lot of issues, we'll usually do a physical right away. Sometimes if it's a person that's older or somebody that has some chronic medical conditions, I'll first want to meet them, discuss their chronic conditions, and do a physical at a different time. Now, the word physical is confusing because it sounds physical, like I'm going to be checking you physically all over the body, and that's where the word stems from. But it's really, a physical is a preventative care visit by me. By me, it's questions from head to toe to try to make sure we touch on the basic things that run through life. So we talk about your diet, your exercise, your teeth care, your bowel movements, your urinary system. We try to go through each one of your systems, and if everything's running fine, then it's straightforward. Everything's great. Let's just do some basic labs. Usually, I do labs on most patients. Check your cholesterol levels. Check your sugar levels. A lot of it has to do with the talking, because if you have a family history of something, then I'm going to check a little more into that. The idea for me is coming to see me is I view it as everyone's into life insurance. This ideally is a type of life insurance. You're coming to assess your risk for what needs to be addressed. Maybe it's nothing. Many people, it will be nothing. But it's a good time to check in, and I try to always tell people about the exercise, talk about the exercise, and discuss it, because exercise doesn't have to be the gym. There was a study done where they compared people that use staircase at work compared to those that use elevators. And when they measured people using 5 flights of stairs, now 5 flights of stairs doesn't necessarily have to mean going up 5 straight flights. It just means maybe 2 flights, 2-3 times a day. And they saw almost as much a difference of reduction of heart attacks in the people that were climbing around 5 flights of stairs a day as compared to somebody who's starting on a statin medication, on a blood pressure, on a cholesterol medication. So the point is, like, there is, it's about figuring out what you need in your life to go forward, and it's also about addressing part of primary care is mental health. Also, it's asking you about stress. It's asking about sleep. So it's about making sure that everything is working right. But for the young person that doesn't really have much going on, it's good just to come and check in, get the basic labs, and move on, and just be reassured that things are good. And then, if you're really in your 20s and everything is fine, you probably don't need to be checked every year. You could almost easily get every 2-3 years. But it's so many people have things that they don't realize. The name of hypertension, the disease of hypertension, is called the silent killer, because many people don't actually feel that they have high blood pressure. A lot of times early stages of high sugar levels are not noticeable to people. And this brings up another discussion about cholesterol. The cholesterol levels that our labs use to decide what is normal, like you were talking about statistics and numbers, and the decision of an LDL of 100 being normal, this decision was based on studying a few thousand white males in Michigan. So it's a specific part of the country, and they decided that 100 of LDL is normal. A number of other studies have since shown that people that live in countries where they're much more physically active, and where they're like in some of the third world countries where you have people working on the farms, their natural cholesterols are much lower. So the point of this is that so it's unclear whether when the lab says a cholesterol is normal, exactly how normal that normal is actually not 100% clear. But the point about this is that we actually unfortunately live in America where we have so much stacked against us. Our jobs include stress. Our jobs include being sedentary. Getting that lunch is so much easier to go to the vending machine and grab a nice cookie, or just quickly go grab something from the fast food store. A lot of times we don't realize how much our body's getting affected. So that's why it's just good to come and get that checkup and make sure things are going good. And then there's sometimes things that people don't realize are issues, like having itchy feet. Okay, I just have some itchy feet. It's athlete's foot. Athlete's foot is a fungus. It's a fungus that could lead to skin fissures. Those skin fissures can lead to cellulitis, which, I'm painting a very dire story, but it could end up being serious. But it is actually something medically should be treated. We should give you something to treat your fungus on your feet so that your skin on your feet is healthy. Skin is actually it's the single biggest organ we have is our skin. And a lot of people just think it's just there, but it actually is an organ and needs to be sometimes monitored. So there's just so many things that coming to a doctor just to get checked up, and then always just to have that relationship. So if something happens later on, you know your doctor, you have somebody to go to, Their mental health. Some people are having stress, and then it's what do you do now with stress? Does everybody in stress take a medicine? No, but there's many different options. Whether it's a therapist, sometimes exercise, deep breathing, a lot of different choices. But if you have somebody to talk to about it, at least a first step. We're the gateway to many the specialties. That's part of what it is. So it's just to have somebody to be able to talk to and do basic labs, basic check-in, and yeah.
The interplay between different fields I find fascinating. I'd spoken to Dr. Klein and to Dr. Mand, and the Fishers and the athlete's foot had come up in the Dr. Mand episode, obviously, and I was talking about how the reverse engineering when sometimes he sees a patient because, let's say someone's not so good about taking care of their global health. They're not seeing a primary care doctor, but they're going to see a podiatrist because, hey, I got this ingrown, it's really bothering me. And he identifies like, hey, you have a really bad fungal foot infection, or, oh, there's a fissure here, or you have an ulcer. Why do you have an ulcer? So, you run labs and you find out the A1C is astronomically high, the marker for diabetes. And now you're working backwards. They had a foot problem, unfortunately, and that kind of led to figure out the underlying cause of that foot problem, which requires greater attention, obviously. The street goes, once again, it's both ways. You can have a primary quarterback, so to speak, someone who's taking care of all these various issues and siphoning off to the correct specialty. And sometimes you go to a specialist and you have to work your way backwards of like, oh, there's a greater issue here that needs to be addressed. And it's always nice when there's, once again, I hate the word holistic in the commercial aspect, but that holistic sense of taking care of patients where you can identify something in a very particular realm, but you're able to generalize it and get someone the broader help that they need, which is nice. And regarding the deck that's stacked against us here a little bit, there's obviously a lot of fortune and a lot of gratefulness for the society and community that surrounds us. But you're 100% correct that, especially for someone who's not acutely attuned to healthcare and personal hygiene, dietary life, a lot of what we consume on a daily basis seems innocent. But the more educated, the more time you put into studying it, the more you recognize how deadly overall this stuff can be. You quoted the study about the stairs versus the elevator. And I wonder how much of that is more of a composite outcome of the person who takes the stairs is just a more considerate person on their health. Meaning that, yes, it shows that there's a difference, but how much is it that person who takes the stairs, there's other modifiers that he's doing on a daily basis that affect his overall health because he's like, you know what, I could take the elevator, but I take the stairs. And it's also the small things in life that matter, right? Because you could argue what's the difference taking an elevator up a couple flights, but there's an additive benefit of doing something routinely the correct way on a daily or weekly basis.
And I guess it's just so misleading also because the world we live in with the advertisements is like you look at go to the cereal department in the store. If you take out one of these Cheerios, Honey Nut Cheerios, or any other one, it'll say on it heart healthy, 9 essential things. It's total false advertising. So many things will say on it, and it's entirely a processed food that is extremely unhealthy for your heart. But they're saying that one part of this food, if you had it in a certain way, would be healthy, and it's actually false advertising. And there's so many foods that say on them 0 cholesterol, but they actually have high sugar, and sugar is increasing your cholesterol. So this is where it's helpful to have somebody to talk to, discuss, and education, because we live in a very world that's stacked against us. Yeah.
There are some diseases. Now, you treat everything, obviously, from a primary care perspective, but there are some disease aspects that you enjoy treating a little bit heavier than others, just from a interest perspective. Which ones are those?
So, I mean, again, it's an evolution because the advent of AI is actually allowing me to also explore some levels of treatment that I haven't done in the past. There's a lot of medical AIs out there that help guide physicians to do more testing and look for things before that we didn't look for. As of today, in June of 2025, my favorites are really the diabetes and weight and A lot of also sleep conditions can be it's all tied together. Diabetes, weight, sleep disturbance, obstructive. Finding people that have sleep apnea and then helping them get the treatment. Optimizing thyroid function. There's many people that are in thyroid replacement therapies, and then they might be losing weight. Their thyroid levels need to be adjusted, and finding the exact right amount of thyroid medicine that a person needs is sometimes a little different. A lot of it depends on your symptoms. Blood pressure these days, there's so many options for treating blood pressure. And I find a lot of satisfaction when I'm able to find a simple treatment that has other benefits. For example, now there's chronic kidney disease becomes an issue as we get older, and many of the blood pressure medicines are protective of chronic kidney disease. There is a group of medicines called SGLT2 blockers that are meant to first for diabetes, but now we use them for chronic kidney disease, but they lower blood pressure also. So I guess blood pressure, diabetes, weight, sleep disturbance, these are my big bread and butters that I like. Thyroid dysfunctions. What else? I guess that's a good start. Yeah. Preventing, a lot of talking about preventing, and exercise, talking about like going for the tests like colonoscopies, mammograms, just getting people to do it. This is going to something that's reducing your risk, and reducing risk is not just by treating your body now, it's by doing things to look for things and fix them before they're an issue. To bring the point of how preventative can be so broad, that book I was quoting Peter Attia, he actually talks about how when you drive your car, looking left, getting in the habit of looking left can extend your life. Because the most dangerous car accident is when you're hit from the left side. And if you make a very good habit of looking to your left, it's going to decrease your chance of getting hit that side. So it's just, the point is like there's just so many components to preventative care that it could be as simple as telling a person, look left, you know? Yeah.
It seems like as medicine has moved towards the concierge acute, taking care of complaints, that are in front of you right now, the field of internal medicine, primary care has really shifted towards owning that preventative space more and more, which I think is exciting because, obviously my bread and butter is taking care of the acute complaint. But the thing that I'm not so good at is when people come in, this happened to me the other day, and they just kind of demand a refill of their blood pressure medications. And I don't know them from a hole in the wall. And I don't know who prescribed this medication. In fact, I know it was no one local, right? And I question the dosage that they're on. It sounds like they're infrequently taking it. And for me, those kind of encounters are so unrewarding because I don't have the time to delve into it. And I also recognize that it's suboptimal care. Like the best way for that patient to be taken care of is by seeing you versus seeing me in my setting.
It does take the relationship, and that's why it's important, because blood pressure, you don't want to do it just one drug done and finished. Usually you need to adjust it and decide what dose is right and discuss, various medicines for the right people. Women that are, in the stages of pregnancy or breastfeeding, you're not going to give the same medicine you give to other people. So there's a number of considerations that go with every treatment plan. Yeah.
Is there something that you would like to see change in the healthcare system in general?
Oh boy.
And you have to pick one thing.
So the one thing I honestly, the healthcare system, I mean, it's impossible to say one thing because like I said, the promise for the treatments out there is mind-boggling. Like we keep on talking about these things, that we could spend days talking about the advancements, but the neglect and complexity of it is also mind-boggling. I guess the one thing that would be the most important would be just stressing the importance of physical activity and the exercise, muscle building, but muscle building not in the sense of like a bodybuilder, but just lifting heavy things, keeping our bones and joints steady and strong so that when you're 70 and you fall, that's not the biggest deal, I guess the most simple physical exercise thing is not stressed enough. not stressed enough, not promoted enough, not set up in ways that are, just as it goes to like city planning, should be set up with proper sidewalks that are safe for people to walk, that are encouraging for people to designing and planning that there are stores close by enough that people can walk to the store. Population health, from, I guess, in that sense of encouraging physical activity, is probably the biggest pet peeve, I guess. Yeah.
Is there something from the emergency room? I've asked this to Dr. Rosenberg in the past, and I'm always curious from a medicine perspective. Is there something that you wish we did differently in the ER? Because the way we view everything in the emergency department is, triaging, the highest level of complaint gets dealt with the quickest. There are some lower level acuity visits that don't really get the time that maybe they should, or the education that they should. But, generally speaking, it's not because they're purposely tossed aside. It's more of a time frame issue.
Yeah. Honestly, I highly respect and don't envy my emergency medicine physician colleagues, because you deal with so much that's coming in the door. You never know whether the next person that you're walking in is a landmine, or they're just somebody that has a little sniffle and cold. One of my most scary memories as a medical student was when a lady came in postpartum saying, "I'm not feeling well," and it looked to me totally like a panic attack. By the evening, she was out on a helicopter from postpartum cardiac myopathy with cardiac arrest, So the emergency, all honor to you people. And in the ideal world, the one thing that would be nicest is which many physicians don't do good at this, is synopsizing. Short, one sentence line, patient came in for this, we thought this, we left them with this. That's what in the ideal world, a very, very short one-line thing saying what if it's, because when you come into the emergency room, you're going to get your blood drawn, your probably troponins checked, your EKG, and you have to look through 100 pages. If there could be just the one-line sentence, this is what we thought it was, we didn't think it's this, it's good to go home, or follow up with primary care, or go to referred to, whatever it is. It's usually can be summarized into one sentence, and then you include all the other papers to examine and go over. But it's I wouldn't say it's a critique of you, because the emergency room these days is one of the hardest places to work, in my opinion.
I wish that I like to sit down next to my patients whenever possible. If it's sitting on their bed, sitting on a chair next to it, it's not always possible. It's not always a chair in the room. I wish that I could spend longer at the discharge with the explanation and really get a little bit more in depth with maybe broader feelings about the visit, just because I think that level of closure and setting them up for success for follow-up would be super beneficial. It's not always available to me, and I really once going to have to triage it. And this is something that this is a second thing that I tell residents, that, like you said, the case of, let's say someone came with chest pain and you did a troponin, which is the heart marker to see if there's a chance they're having, in the colloquial sense, a heart attack. And let's say that marker is normal and you checked it twice and you did all the right things from an emergency medicine standpoint. Everything looks okay. You want them to follow up with a medicine doctor or a cardiologist. And I tell this to residents, right? We have a chief complaint that we learn to ask people, what is the chief complaint? I say, ask the chief concern, right? Someone's chief complaint can be chest pain. Their chief concern is, their father died at 40 from a heart attack and they're 40 and they're worried about dying from a heart attack. Now, unless you use the correct vernacular, the right words to express and alleviate that concern, if you walk in the room and be like, the tests look great, everything's good, I want you to follow up with your primary doctor in 2 days, they might leave and just be like, okay, I think I'm okay, but I also don't really feel that sense of relief that they're kind of looking for. And sometimes you can't always give that full sense of relief, right? I've heard this spoken about before in other forums, where the better doctors occasionally look like they're more self-assured about what they're saying. And unfortunately, the reality in medicine, more often than not, is there's a certain degree of hedging that exists in the medical care community, right? You're not always 1,000% definitively certain about what's going on. Perfect example is when I see pediatric patients with abdominal pain with a fever. Sometimes it's just because they're a little unwell or they have a gastroenteritis, but when parents ask me, so it's a virus, I'd be like, well, I don't know that it's a virus because none of the viruses tested positive. His belly feels good right now. His vitals are good. I need you to watch the fever. I need you to make sure he's not consistently vomiting. I need to make sure the belly pain doesn't get worse. That doesn't go from his umbilicus, his belly button, down to his right lower quadrant. Like, I have to give all the appropriate guidelines and precautions so that if that case is the one in the whatever hundreds or whatever, that it does get worse and it was just an early appendicitis, that they're prepared to take care of it and do the next right thing. But it's so much more reassuring when the doctor says it's probably a virus, you're good to go home. And it's inauthentic, but it's more reassuring. And it's like that balance of seeming confident, knowing the information, but letting someone know that there's multiple possibilities here. It's a really tough balance.
It is. It's one of the most challenging things. But getting back to that thing, I did actually wanted to mention that that's one of the lucky things I have over here working with you in your department, because a lot of times we do send patients to the acute care, and then you give me a call and tell me exactly what was going on. So that is a unique thing that we were able to do over here. Yeah.
And for me, like, it's a nice thing on my end to see patients that I recognize, like, sometimes, like, this interplay in medicine, I'll see someone for an acute issue and I'll see them and I'll be like, when was the last time you saw a doctor? Right. And clinically, I'm like, there's more things under the hood here that I can't unwrap, but I need you to see a good doctor who can sit down with you for 40 minutes and unwrap all these things, because otherwise this is a ticking time bomb. And formulating the relation. I mean, probably if you have to say what the essence of an ER doctor's job is, it's formulating relationships, right? Because I have to formulate relationships with surgeons and medicine doctors and cardiologists and gastroenterologists, admitting physicians, outpatient, podiatry. Like, I have to have a relationship with everyone. So when I see someone for a complaint that I can't entirely manage, I can make sure I've gotten them to the right hands. And certainly one of the things that is rewarding here is that close connection of, like, I see someone the night before, I'm like, they need to follow up the next day. And I don't even know that they're necessarily the type of person that's going to take that initiative, but to be able to have a system that helps to prompt to get people where they need to be is pretty rewarding as well. To close up, I want to ask you a last question here is, if you had the opportunity, I don't know who's listening to this program, maybe no one, but hopefully someone is, but let's say it's someone who is considering the medicine route and is like a young, enthusiastic, pre-medical individual, what would be that piece of advice that you would give them with what you know today that might help steer them and hopefully direct them towards, a fruitful career in medicine? And it can't be just do something else, because everyone, it's got to be something that is
because I do
piece.
think for the right person, medicine can be a good thing. I think it's really one of the biggest things is being open-minded and I think honest with yourself, and also realizing that medicine has a tendency to be very boxy, but it's not as boxy as it seems. In other words, you can do emergency medicine potentially, right? But you're licensed as a physician. Once you've gone through medical school residency, you can open your wellness center. You can function as integrative physician with an emergency medicine physician training. The residency training that we get is on top of our 4 years of medical school, and it's meant to give us excessive training in specific areas, but sometimes it boxes us into things that we may not fit perfectly into unnecessarily. So I guess what it is like, pick an area, be honest with yourself, an area that's good for you, but there's also a lot of change that can happen. Again, quoting to this guy, Peter Attia, he was a cancer surgeon. He did surgeries on people that have cancer, and then he found that unfulfilling, like he was just fighting people towards their death. And he said he switched his whole thing to going to longevity medicine, but he didn't actually do a full residency in internal medicine. He mentored with somebody, and he used his knowledge of medical school and training from before that. So I guess you need to be in it for the process. Life is so confusing these days because life is changing so fast that I don't know if I really have much better advice for anybody else, because the world is changing so fast. But I just say, just be honest with yourself, and if it resonates with you and you find yourself doing well in it, go for it. If you find yourself regretting it all day, don't stick with it, I guess. Definitely, there's a lot of options out there. I think it's being self-honesty is the most important thing, is, Yeah.
Right. I think two things can be true, right? Like, I think it's true that people have to create their niche and their specialty.
Yeah.
And there's also an importance of globalization of healthcare, right? Where you have to be in your lane, but there are values to having access to other lanes as well and providing healthcare in a more general sense. You know, the old time doctor did it all, right? There is value to that, and there's value to specialization. I think part of what we do here is being able to broadcast healthcare in a more global sense, right? That's the value that's added here, but it's also not me directly taking care of patients. But if all I did was every day be in an emergency department or an acute care setting, there's a tremendous amount of value there, but there's a value added component here. I think to kind of wrap up and to where we started, right? The smelling the roses, that uncompensated time that your father spent in the evening, that rounding out a medical career with other value adders to provide a more comprehensive level of care when it's authentic and genuine. I think there's a tremendous amount of value to that. So I think that's it's a meaningful way to kind of end the podcast. And I appreciate you coming in, educating us on the trials and tribulations and the values of obtaining a primary care doctor. I think after this, I'll definitely have to make an appointment. Maybe not. I'm the worst patient. Doctors are the worst patients. But I appreciate you coming in and sharing your knowledge with us.
Yeah. Okay. Thank you.
Thank you
for taking your time.